We're good to go.
Good evening, friends. Welcome to this Tuesday evening meetings from the Department of Critical Care Medicine and other specialties from Yashoda Group of Hospitals. We have been doing this webinars for over the last 3 years or so. We try to bring some topic of interest to all our clinicians and something to actually learn from these topics. And it happens to us, our neuro team, Dr. Subbaiah Chowdhary and Dr. Sagari, made us to actually interact and discuss with Dr. Zain for his movement disorder experience. And more particularly, which was interesting to all of us, is the emergencies in movement disorder, which was actually a little catchy to me. We always think about movement disorders are related to the elective phenomenon and OPD-based or IP-based treatment. But he brought us some interesting insights into it's not only limited to the OPDs or IP. In intensive care unit, when these patients present to the emergency with some of these maybe catastrophic life-threatening movement disorders, which need to be given an adequate attention, and they are not uncommon, even though they are not very commonly seen, but they are not uncommon, and more so when you have a high neurology load. And the initiating event may be something else. They may present to you with an autoimmune encephalitis or a viral encephalitis, but later, when some of this limbic system or basal ganglia gets affected, later part, they land up in some of this movement disorder. And many times the drug induced, and many of the times the maybe anesthetic agent related, antipsychotics related, movement disorders, and more so, the first experience of movement disorder, when actually Dr. Zain showed me some of his pictures. In my medicine days, in my medical school days, when I saw a patient who was being injected metoclopramide, and the patient suddenly turned to be a movement disorder emergency with an extrapyramidal symptoms. And we were all scared in the bedside, seeing that patient's behavior, altered sensorium and all. Then suddenly my senior nurse from the back says, "Hey, don't worry, guys, give a promethazine or a Finnergan, he will be all right." And for our surprise, a couple of ml of promethazine made the patient back to normal. So that is the days from where we started our learning from medical school days of extrapyramidal symptoms of metoclopramide's adverse effects. To today, we are talking about neuroleptic malignant syndromes, malignant hyperthermias, serotonergic syndromes, many drugs leading to overlap of this. Coming back to the ICUs, we have a more complex challenge. The population is very heterogeneous. We come across many overlaps of septic encephalopathy, metabolic encephalopathy, and maybe compromised perfusion, compromised oxygenation, toxins, and over and above, withdrawals are not uncommon. We see a good percentage of our patients in ICU. Either we are talking about a alcohol withdrawal or a nicotine withdrawal or drug addicts, or sometimes a benzodiazepam withdrawal. So all this has been not uncommon to us. So to actually bring us through that, we have Dr. Zain, who has been a seasoned clinician in the movement disorder, has gone through his medical school in India, but from that he has pursued a long career in neurology to a movement disorder. And to introduce him, I will request Dr. Subbaiah Chowdhary, who is our senior consultant in the Yashoda Hospital, Hitec City, and he has been a part of many of our intensive care cases. And we have one more young, enthusiastic, dynamic epileptologist and been expert in that, who always interested in interacting, Dr. Sagari. Welcome all three of you, Dr. Zain, Dr. Subbaiah Chowdhary Garu, and Dr. Sagari. It is a privilege and honor to have three of you on board.
So, good evening, Dr. Zain. I think you can, he has done his MBBS in Rangaraya Medical College, Kakinada. Later, he shifted to US. He did his his neurology and fellowships in the US. And now he has done his subspecialization interested in movement disorders. So, a lot of his CV is very long. I think it will take up to 8 p.m. So let us, his talk itself will tell us uh, all the all his CV about all his CV. So let us start, Dr. Zain. I don't want to take your much of your time.
Perfect.
Welcome. Yeah.
Thank you so much. Thanks first of all to you for this opportunity and to Dr. Kola for. So here you go. I'm going to share the screen. Okay. Can you see my screen? Can you see my
Yes.
screen?
Yes.
Yeah.
Yeah. Okay. Perfect. So I'm going to talk specifically focus on those movement disorders which you can encounter in a ICU setting. And the first half of my talk, I'm going to focus on one disorder which can happen in variety of settings and variety of manifestations. Eventually, the second half, I'll be focusing on neuroleptic malignant syndrome and its differential diagnosis scenarios. So here you go with the first video. This is a young woman, about 25-year-old, who was pretty healthy, who within 3 days develops altered sensorium to the point that she is not able to talk. She is not able to identify her family. In addition to that, within a day, which she develops these movement disorders, which you're going to see in the video, which were thought to be seizures. And whenever we see any, did not capture any epileptiform discharges. And what you're seeing in the video is repetitive movements, similar type of repetitive movements which are happening in head and neck region, in upper extremities and lower extremities. It's pretty pronounced in right upper extremity and right lower extremity. Similar type of movements without any specific abnormal posture, which goes on for hours together. These are called stereotypies. Whenever you see, I think the straightforward take-home point is a young woman with change in mental status with stereotypies, your first differential diagnosis should be anti-NMDA receptor encephalitis. Yes, it is rare, but it's treatable. It's straightforward clinical picture. Some of you might have watched the movie or read the book Brain on Fire. This is one such example, a classical picture, right? So whenever you see this scenario, first and foremost, look through the history, look through the medications. Are there any antidopaminergic medications which are exposed? Rule out that, right? Here you see those movements, same stereotypical movements which are happening in the face. Keep seeing exactly same movement. Happens again and again and again, right? Stereotypies. Now, when you see this picture, you think about NMD encephalitis. I'm going to walk you through the NMD encephalitis now. This particular receptor, which is present in different locations in the brain, neurology is all about where exactly is the pathology. That's what dictates your signs and symptoms. Now, these movements which you're seeing are actually resulting from the antigen-antibody complex, which is being, pathology is being formed at brainstem level, especially at the brainstem central pattern generator, which is located predominantly at the pons. In addition to that, you can have pontomedullary respiratory network, which can affect the breathing and hypoventilation. Many of these patients eventually will also need intubation too. And very common to see autonomic instability again because of effect on the noradrenergic pathways, and they can also inhibit GABAergic neurons, causing some psychosis, catatonia picture. Usually, it's a combination of all these things. You see this progression. You can notice one thing. Very common to see within 1 week, many of these symptoms or signs evolve. So it's pretty fast, ICU, right? You can see a viral prodromal picture immediately followed by a psychiatric symptoms, which can be psychosis, agitation. It can even lead to catatonia and seizures too. Eventually, patient will develop movement disorders. That's what you're seeing in the clinical picture, and also dysautonomia, hypoventilation, and seizures. Right. This is one of my favorite articles from JNNP. You can see they've gathered humongous number of cases and they put together all those movement disorders were present in almost 100% of the cases. 100%. One or other movement. It can be any type of movement disorder. Yes, stereotypies are common, but you can also see chorea, dystonia. I'm going to show those videos too. Psychiatric manifestations are second. The reason I'm specifically mentioning about psychiatric manifestations is because a good number of these cases are discharged from emergency room saying that these are psychogenic. Unfortunately, sudden onset of psychiatric symptoms in a young person is thought to be psychogenic, but think about this diagnosis. Don't never discharge these cases. This will be disastrous then. Seizures, cognitive problems, abnormal EEGs can be present, form discharges. CSF abnormality and MRI abnormality are not that common. Right? If you come focus on specifically movement disorders, what type you can see, you can the blue and the orange and the red are the predominant ones in the picture. The blue is dystonia. Dystonia means, I'll show you a video in the next slide. Stereotypies, I've just explained it. Chorea is more like a dance type of movement, but the rest of the colors you can see any type of movement disorder can manifest in these clinical picture. Whenever you see such patient where you are suspecting autoimmune encephalitis, obviously you will rule out other infectious, toxic, and metabolic causes. Then brain imaging is required in these cases. If you think about NMDA, many a times the brain imaging will be normal. Sometimes there can be transient hyperintensity, T2 hyperintensity in the medial temporal lobes. Lumbar puncture is required. Again, you're thinking about differential diagnosis. You think about other autoimmune pictures too. You will have to do lumbar puncture here, also to rule out infections. EEG, as I told you, don't want to miss any seizures, and seizure can be part of this picture. Antibody studies where you do anti-NMDA if it is pertinent. You also do in serum and CSF too. When you think about MRI, many a times, as I said, it will be normal and not routinely performed, but PET scan is something to think, you can consider. If you happen to do a PET scan, there can be increase in frontal occipital gradient of cerebral glucose metabolism, which can correlate with the disease severity. When you do CSF, again, many a times it can be normal, but you want to do CSF to rule out other etiologies, including infections and also leptomeningeal metastasis. And sometimes you can see leukocytosis, lymphocytic pleocytosis picture, and oligoclonal bands can also be found. And so get anti-NMD encephalitis because that is more specific than the serum anti-NMD antibody. Right. When you identify this case, when you happen to come up with a diagnosis, your clinical diagnosis, again, clinical diagnosis, not all the times you can find antibody, but thinking about this diagnosis and coming up with the treatment is important. First line immunosuppression is with high dose IV steroids or IVIG or plasmapheresis. There's no head-to-head clinical trial to compare these, but you just have to choose based on the clinical scenario of the patient. Second line therapies, if you happen to fail these, sometimes you can add this combination rituximab or cyclophosphamide, but as you know, they can take some time for them to work. Associated tumors is something which you have to look out for. Teratoma, especially in young women, teratoma is something to look out. And if found, it should be removed. That's one of the treatment strategies which can help significantly. You see this young woman. This is a person within 1 week, she develops these movements along with altered mental status, admitted to ICU. She has these bouts, these episodes where suddenly her jaw opens, right? abnormal posture, sudden abnormal posture. It's not a fixed deformity. In addition to that, her vocal cords are also involved. Now she has that jaw involvement, jaw closing. This is all dystonia. Dystonia, by definition, means that there's some abnormal posture with or without tremor, which can be exacerbated with some movements, right? The whole body is also involved. The jaw is the predominant region which is involved, right? Now you can see position. You might have heard about this word in tetanus, uh, right? This is dystonia, which is causing the arching of the body. This patient was again young woman, altered abnormal movements, ICU setting, anti-NMD encephalitis was thought were done. Acute first line immunosuppression. Along, she was found to have teratoma. After resection of teratoma, this is how she looks. Right now, she is following commands. She is answering questions. So this is the video. This is a video from Archives of Neurology. Again, the reason I brought this video is just to make you understand that teratoma is something to look out for and can help in the treatment. In terms of association of ovarian teratoma, 60% of the patients with NMD encephalitis have underlying tumor, especially ovarian teratomas, which can be resected. When you happen to see the same clinical picture in a young man, unfortunately, there is no specific tumor which is associated, and we do not have any current guidelines or recommendations on how to look for those tumors and how often to follow them. If you do not find a teratoma in a younger woman, then it's important to follow up on those cases, especially every 2 years, to make sure that there is no evolution of teratoma. If it happens, then you have to resect it. Right. Moving on to something similar, this is one of the two in such age hospital. Is a 3-fold event. Secondary to abnormal involved body. Movements have started 2 weeks during the previous hospitalization, and then they reduced in frequency at discharge, and mom noted worsening of the movements in the last 2 days, which were described, just couldn't stop those movements in the whole body. There were no associated fever, breath, nor it had inconsolable crying. This is a full-term male infant born at 38 weeks without any perinatal complications. There was some acute hypoxic respiratory failure at 2.5 months and complicated by a hospital stay, which led for 22 days and discharged home 10 days prior to the current presentation. So there was first hospitalization with respiratory failure. There was a gap, and then comes the movements. That first hospitalization to be because of RSV, which required short course of immunosuppression along with antibiotics. The video EEG were done in this hospitalization for those movements without any epileptiform discharges noted. The CSF lumbar puncture was done. It was negative. There was also negative for any infections. MRI was recommended, but again it was not done. It was based on the family's preference. Examination was overall within normal limits, except those movements which you're going to see in the video. Yes. So this is the second hospitalization, 10 days after the first hospitalization, 10 days after RSV bronchiolitis and Neisseria meningitis pneumonia. Right? These movements were going on constantly. This is chorea. This is dance type of movement. This is flowing type of movement from proximal to distal body regions, which is affecting multiple regions of the body, including the trunk. Because the trunk and multiple regions are involved, this is called generalized chorea. A young boy 3-month-old boy with acute onset generalized chorea after some infection, after a few days infection which has happened. So when you have this kind of clinical picture, again, to think about para-infectious or autoimmune etiology, and something which you can think is Sydenham's chorea, it will be too young to have that. Anti-NMDA receptor encephalitis was also thought in this kid. Eventually got the anti-NMDA receptor and antibodies, and it was found to be positive in this case. And this was in the serum and CSF. Eventually, the kid was treated with a short course of steroid, and there was significant improvement of that. There were, again, young boy. We don't have any specific guidelines on what tumor to look at and how often to look at. We did not find any, but the movements did not recur. Right. So association with any other infection, especially this NMD encephalitis is associated with HSV encephalitis. It is thought that HSV encephalitis unmasks the underlying anti-NMDA receptor antigen. That's what triggers these antigen-antibody reaction. But this is a classic story. Whenever you hear HSV encephalitis and followed by a few days or weeks, and then movements develop, think about NMDA receptor encephalitis. Again, it's a treatable condition. Okay. Something similar, but not the same diagnosis. I brought this video just so that, just to show how important neurological history and examination is. This is very interesting video. Again, same picture, young woman, right? Young woman, I will also tell you, patient has been recently diagnosed with ovarian teratoma, right? You might think straightforward diagnosis, but look at this case. Right, so day one, she presents with some change in mental status. She has difficulty opening her eyes, bilateral ptosis. The examiner is asking her to look to the right or left, and she's not able to do that. This is external ophthalmoplegia, bilateral, associated bilateral ptosis, acute onset, associated change in mental status. By day 3 or day 4, she starts having these movements, right? Having these movements happening in the head and neck region. Again, looking like video where same type of, now you can see the whole body is also involved. Again, same type, the leg flexes and then extends, and then again extends. Whole. So let me repeat the case. Movement disorders with stereotypies, recently diagnosed with ovarian teratoma, right? If you think straightforward like this, NMD encephalitis, yes, it's high in the differential diagnosis, but we have to come up with broader differential diagnosis. On examination, she also has bilateral ptosis and external ophthalmoplegia, which is not commonly seen in NMD encephalitis. So that should make you take a step back and think about alternate diagnosis. Then when you're thinking about alternate differential diagnosis, especially because of acute subacute onset, you also think about other autoimmune causes, provided you have ruled out your infectious etiologies already. On examination, patient also has loss of all deep tendon reflexes. Patient also has weakness, which is progressively getting worse, and that was one of the reasons for a patient to be admitted to the ICU. Thinking about NMD encephalitis, both the CSF and the serum antibodies were tested, and both were negative. Then the other autoimmune workup has revealed the second differential diagnosis was loss. CSF also showed albuminocytological dissociation, right? So Bickerstaff encephalitis was the second differential diagnosis. Bickerstaff encephalitis. So weakness, loss of joint, deep tendon reflexes, albuminocytological dissociation. So that few weeks she had area, and her Campylobacter jejuni antibody also came back, antigen came back positive too. So this was a case of Bickerstaff encephalitis. Again, it is treatable. You have to think about immunosuppressive treatment, especially IVIG or plasmapheresis. She got that, and this is the second part of the video. After the immunosuppression treatment, you can see that the movements are better. She was slowly following commands too. That's better than the first part. She's smiling now, better. So point of all these videos is these are treatable conditions. Don't miss that. Moving on to the next one. So that finishes my first half of the talk. Moving on to the second half. This is again a rare problem, but again, you might encounter this in a para-infectious way. It's a treatable condition too. This is about 50-year-old woman who presents with some abnormal movements. So look at the video and then I'll describe the movements. So you can see sudden jerky movements which are going on in the head and neck region. In addition to that, what strikes at you is those eye movements.
You'll notice that they're random and chaotic, multi-directional. They do have a tendency to be primarily in the horizontal direction. There's no significant pause between movements.
Sudden jerk extremities or the whole body, you call it as myoclonus. And when it happens in eye movements, that's when you use the word opsoclonus. You might think that these fast jerky eye movements, you can think about alternate differential, that is ocular flutter. But in opsoclonus, the eye movements are constantly moving in different directions. It's not just horizontal. Plus, there is no gap between the saccade. When the eyeball goes to one direction, there's no gap there. It just comes back or goes in different direction. Absence of intersaccadic interval with random chaotic multi-directional movements. It's called opsoclonus. When you have this combination, think about opsoclonus myoclonus syndrome, which can be manifest in a variety of clinical settings. The reason I brought this in the ICU picture is because para or post-infectious associations have been described in numerous number of infections, which includes viral infections, bacterial, and many of these cases can also be associated with altered mental status picture too. And these are treated with transient immunosuppression that should be sufficient enough for improvement of mental status. The eye movements will gradually improve. Not just that, it can also be seen in paraneoplastic picture. If you see this in kids, think about neuroblastoma. If you see in adults, if you're thinking about paraneoplastic, small cell lung carcinoma or breast adenocarcinoma is something to think about. Anti-RI and ANNA antibodies can cause this kind of picture. We had a similar case with COVID, which was also published during the COVID pandemic too. Right. Moving on to the next one. This is a myth. I want to prove that myth wrong, and this is important for you to understand. So what we all were taught is anytime a movement resolves in the sleep, you think about a movement disorder. For example, tremor, dystonia, something. When a movement does not resolve in sleep, think about seizure, right? This is what we were taught. So look at this video. So patient is sleeping, right? No movements. Now somebody is waking him up. He tries to open his eyes. Then the movement starts. You can see jerky movements which are happening in the neck region and also the left side of the face. They're irregular, fast, jerky movements which were not present when the patient was sleeping, but when he was woken up, that's when it has happened, right? Again, going by what you were taught, you might think that this is a movement disorder. You will also think that this is not a seizure for sure. And with your confidence, you might not do the EEG, but that's not correct. The EEG was done in this patient, and this patient was found to be in epilepsia partialis continua because this was going on for about 20 days or so. Eventually, with the depth electrodes, patient was found to have a gliosis in the cortical region, the temporal area, and eventually it was resected and patient improved. This is similar clinical, this is not EEG, but something which was published in Archives of Neurology in 1977. On the left side of the image, the EEG did not show any epileptiform discharge when the patient was awake. So which is quite similar, asleep versus awake, like what I have shown. So EPC, epilepsy partialis continua, always persists during sleep is a myth. It's wrong. Right? Don't forget this. Don't forget don't miss these diagnoses.
Channels in certain parts of the brain.
All right, I think I'm doing good with the time. Okay.
Yes.
So this is a 60-year-old man who presents to the hospital, eventually gets admitted to ICU because within 2 days his mental status got worsened. So it's fast progressing change in mental status. Then the ICU doctor sees that there's some sudden movements which are happening, which just last for a second and then resolves. They do the EEG. The EEG is fine. No epileptiform discharges, including capturing those movements, right? And then they call neurology consult. So here you go with the movement. And the sodium level, the blood sodium level, normal is 135 to 145. The sodium is 132.
Channels in certain parts of the brain that are triggering the
right? You see that just for 1 to 2 seconds, that's it. See that? Right side of the face, right upper extremity. Look at the video once again. Look at that. See, right side of the face, right upper extremity, and a little bit of right lower extremity. See, there's some abnormal posture associated with that movement. Very brief contraction. Again, it's not. EEG did not show any epileptic discharge. This you can think that this looks like a that's too, but actually called faciobrachial dystonic seizure. That's the diagnosis. It's rare, but it's treatable. Every word in this faciobrachial dystonic seizure is a misnomer. It can usually affect the face and upper extremity, but it can also affect the lower extremity, as you just saw in this video. It's not exactly dystonia, but it has a little bit of dystonic posturing. It sounds like a seizure, but it's not a seizure. When you have this clinical picture, it's a straightforward, direct diagnosis. The answer for that is voltage-gated potassium channel antibody causing faciobrachial dystonic seizure. The voltage-gated channel with movements treatable. The percentage action, steroids or IGR, they can also cases. All right, moving on to the next one. You all in the ICU settings might have seen numerous number of cases of post stress. You all might have post respiratory arrest. It that you all have something, but it can. This is one such video. This is, I think, you just that this page. This is about 40-year-old who was.
Got disconnected?
Sir, his internet is not stable. He got disconnected. I think he will join again.
Okay. Just to carry that continuation, I think both of you have seen this scenario, sir. I had an experience of a young boy who was actually picked up diagnosis of the autoimmune encephalitis after this choreal movements or this movement disorder kind of phenomenon. From there, they actually gave a clue that this can be an autoimmune encephalitis. Yeah, Dr. Zain, I think we lost your connection. So,
Can you hear me now?
yeah, please. No.
Sorry about that technical problem. Right. So I was saying this is a 40-year-old man with who was binge drinking, went into respiratory arrest, got admitted to the hospital, ICU, got resuscitated. Obviously got resuscitated. Eventually, things go fine. From overall bigger picture, gets discharged from hospital. 10 days after the discharge from the hospital, comes to the neurology clinic with this. New. 10 days after the hospital discharge. Sitting in a wheelchair, right? Not much abnormal movements which are present at rest when he's not doing anything. See that? When trying to do some kind of activity, that's what brings those sudden jerky movements, myoclonic movements, which are irregular in pattern, which are happening in both the extremities, especially when he's doing some action. So it was not present at rest. So this was action-induced, multifocal, multiple regions, sudden jerky movements are happening, irregular. They're not synchronized. This is action-induced multifocal myoclonus, which has started few days after the discharge, post-respiratory arrest, eventually leading to cardiac arrest, right? This is a classic picture of Lance-Adams syndrome. Lance-Adams is not common, but almost always it's associated with the respiratory arrest. Usually it is later in onset, in contrast to myoclonic status epilepticus picture, which can happen within first day of hospital admission, right? The pathophysiology is thought to be hypoxic brain injury. Again, not exactly sure why it takes such long time for it to evolve. The problem here with Lance-Adams syndrome, even though overall bigger picture prognosis is good, the problem is this myoclonus can be extremely debilitating. You can see that patient you just saw now is not able to walk, not able to eat, not able to do anything. He's just sitting in the and every medication for that myoclonus, even at higher doses, there can be extremely drug resistant picture. That patient underwent bilateral globus pallidum deep brain stimulation, which led to about 60 to 70% improvement in that myoclonus, is doing better. So Lance-Adams syndrome is one of the differential diagnoses for post myoclonic picture. Okay, all right. So this is a middle-aged man who has a history of hypertension, uncontrolled hypertension, diabetes, hyperlipidemia, is also a known smoker who presents with acute onset weakness of the right side of the body. In addition to that, also has these sudden jerky flinging movements which are happening in the right side of the body. You can see the right upper extremity and right lower extremity. These are wide flinging movements. In addition to that, the distal regions, there is some flowing type of body movement. This is a combination of ballism. Ballism means flinging type of movement, and chorea, which is as I just described, it's happening in the distal body region. It's happening only in the right side of the body. That's why hemiballism. Hemiballism. It happened in association with weakness. When you see this acute onset picture, you have lesion, and this patient was found to have and see that this patient, sorry, yeah, so thalamic subthalamic region, GRE positive lesion. There was hemorrhage in that area. It's thought to be acute. It's thought to be because of uncontrolled hypertension. When you see this clinical picture, the good news is these movements, many a times they resolve on its own. If, because these are wide flinging movements, we have started him on low dose antidopaminergic medication, especially atypical antidopaminergic medication. There was partial response. Eventually, we had to add a dopamine depleting agent like tetrabenazine, and that's what improved his symptoms. So this, the concept of stroke or intracranial hemorrhage can cause acute onset movement disorders. And, especially these cases are usually admitted to ICU too. The most common one, which can result, is chorea or ballism, but other movement problems can also happen in acute fashion too. The second most common one is actually dystonia. We had a patient with dystonia, dystonic appearing status, acute onset status epilepticus picture post-stroke too. So variety of brain regions lesions can cause these movement problems. In medical school, we all are taught about chorea, acute onset chorea, stroke-induced chorea is caused by contralateral subthalamic nucleus. That's one of the area, but also think about globus pallidus and all those. Right. Moving on, some acute diseases. I'm going to talk about dystonia and Parkinsonism. Starting with dystonia, this is a young woman, girl who had dystonia for about 10 years, which eventually affecting the whole body, which pallidum implantation. With that deep brain stimulation implantation, she had improvement of her dystonic symptoms, and she almost, went back to her, her regular school, and she was doing good. 4 years later, it was time for the battery replacement for the deep brain stimulation. That's when the battery was replaced with a different technology. That's what led to this acute worsening of dystonia, to the point that she was not able to eat or talk, and even had difficulty with the breathing.
Can you tell me what's your last name?
You can see that abnormal posturing of the neck, which always wants to go to the left side. This is dystonia of the neck.
Turn your head
There
to
was
the
also
right.
some gagging sound which was heard too. So vocal cords, the throat was also affected. The whole body was affected, especially these movements were getting worse when she was doing some activity. And even the trunk had a predilection to go forward all the time. She was not even able to walk.
To the left.
With this scenario, we had to admit the patient to the ICU with a diagnosis of status dystonicus, because with all the basic medications for dystonia, it did not improve, and it eventually started affecting her muscles, causing myoglobinuria, and eventually leading to renal, affecting the kidneys too. So we admitted the patient to ICU, did a little bit higher level of treatment of dystonia management, which includes anticholinergic medications, benzodiazepines in IV fashion, muscle relaxants, addressing all the electrolyte disturbances and kidney failure. Partial response, but full response had to be debraced with similar knowledge. In a couple of days, she went back to her baseline. She's now talking, walking, still has some dystonia, but not that much, right? This is the clinic setting.
Close your
Within
eyes.
2 days, she comes back.
months backwards from December.
December, November, September, October, August, July, June.
What kind of sports do you like?
So you can see her walk too. Right. Still has that little bit of dystonic posturing, especially with the feet, but overall she looks a lot better.
I can go.
So as I hear that, you know, there are more and more surgeries are being done for the deep brain stimulation here in this town. This is something to look out for whenever you have sudden interruption of deep brain stimulation, or if there is any infection which is affecting these people, they can go into this status picture, something which you require with addressing that underlying problem. If it is infection, if it is deep brain stimulation interruption or interruption of medications, addressing those problems, addressing IV anesthetics or anesthetics, nothing helps. That's when you got to think about emergency deep brain stimulation. This is one such indication to do emergency DBS. Okay. This is a 70-year-old man who was diagnosed with dementia. Over the time has developed psychosis. With the psychosis, just a week prior to this, patient was given antipsychotic medications, which was a typical antipsychotic medication. Within 7 days, goes into this phase where his temperature is now 104 degree Fahrenheit, has got elevated myoglobin. Now the kidney function is getting affected. The cardiac respiratory is also getting worse. Is very, very rigid like a board. In addition to that, he can hardly make any voluntary movements. Some jerky movements, but rigidity was predominant. Overall, hardly does any voluntary movement. A kinetic pattern. So acute onset of a picture which looks like Parkinsonism, which has happened in the setting of exposure to antidopaminergic medication, that especially within 5 to 15 days, you think about an idiosyncratic reaction called neuroleptic malignant syndrome. Again, this is an idiosyncratic reaction. It's tough to predict who will get it, but this can happen in the setting. It can happen in the setting where you can withdraw levodopa, causing Parkinsonism picture, hypopyrexia, which I'm going to discuss, but it can also happen because of blockade on dopaminergic transmission. It's very rapidly progressing. The rate of mortality, if not addressed timely, again, this will require ICU admission for sure. You'll need to address all those medical things, which includes high fever, renal, cardiac, respiratory, and then you remove the inciting agent and treat it with medications like dantrolene, which help break down those actin-myosin bonding. Already described all these clinical features. So management, you'll need dantrolene, which is treatment of choice here. You should not be using anticholinergic medications thinking that this is dystonia, because it will elevate the temperature further, which can be pretty detrimental, right? If there's any overlap with catatonia, you can think about electroconvulsive treatment too. You think about neuroleptic malignant syndrome, one of the differential diagnoses which should come to your mind is serotonin syndrome. This is a young man who has a history of bipolar disorder and chronic pain disorder, who was being managed with multiple pain medications, including and also antipsychotic medications, especially selective serotonin reuptake inhibitors. Those combination medications was probably the result of this, where the patient presented with acute onset change in mental status, along with fluctuations in his blood pressure and heart rate, with
I get you to count the months backwards from December back to January.
You can see in the first video to your left, there are sudden jerking movements, those myoclonic movements which are happening in different body regions at different times. This is called multifocal myoclonus. In addition to that, examination also had clonus, myoclonus, clonus, diarrhea, autonomic dysfunction, change in mental status, which is acute in onset. You look back at the medications, always, any case, look back at the medications, think about iatrogenic causes. Was found to have multiple serotonergic medications in his medication list. All those offending agents, right? See this myoclonus, it gets worse when there's some kind of activity which is being done. All those offending agents were stopped. In addition to that, these patients are also admitted to ICU, addressing the basic, the airway breathing and the circulation, addressing all those. And the treatment of choice here is cyproheptadine, which was given. Eventually, the patient got.
The months backwards.
December, November. I've been working on these for a year.
To put your arms straight in front of you, palms up. That's it. Keep them there. Keep them there. Good. Very good.
Right. A lot of improvement in those movements, diarrhea, clonus too. So serotonin syndrome is not common, but something to think about. These are all the agents which can cause serotonin syndrome, not just your SSRIs or SNRIs, but also think about MAO-B inhibitors or non-selective monoamine oxidase inhibitors, things which can enhance serotonin release, like amphetamines, or somebody who has drug abuse with cocaine, MDMA, all that can contribute here. Electroconvulsive therapy can also contribute to. Okay. Just a couple of things I want to point out here. When you see hyperreflexia or common in syndrome, malignant syndrome, and not present in serotonin syndrome. Same thing with diarrhea too, more commonly seen in serotonin. Otherwise, there are a lot of things which overlap between these two conditions. But your history, your exposure to those specific medications, that history will guide you towards the treatment. Something similar you can see in Parkinson's disease. If you just happen to see a patient with Parkinson's disease who was diagnosed for about 10 years ago, who got admitted to your hospital for some gastrointestinal surgery, because the GI surgery is being planned, those medications, those dopaminergic medications were stopped suddenly. That can lead to this picture, which can look like neuroleptic malignant syndrome. It's called Parkinsonism hyperpyrexia syndrome. Clinical picture exactly looks like that, but here the history is not exposure to antidopaminergics, but the history is sudden stopping of dopaminergic treatment. Identifying that and reinitiating those treatment is important. Or if you're planning some GI surgery, think about alternate ways of delivering that dopaminergic medication, like sublingual or something, or transdermal patch. Think about alternate ways of delivering the same medication. Okay, the last case for today, never miss this. This is a patient who comes in with sudden onset of movements of the right side of the body without any associated weakness, who never went to the doctor, comes to the emergency room, acute onset movement problem, emergency room, thinking about stroke, got blood glucose, and he was found to have blood glucose of 450, which was non-ketotic. So non-ketotic hyperglycemia causing acute onset movements without any associated numbness or weakness or aphasia, right? So the flowing type of movements in the right side of the body only. This is a case of hemichorea. One side of the body is hemi. These are choreiform movements, right? The right upper extremity and extremity is affected. When you see this clinical picture, brain, whenever you see unilateral movement disorder, brain scan is must. You want to look at contralateral structural lesion, and this is what this patient has. Left side of the basal ganglia, the caudate and the putamen, you see T1 hyperintensity without any associated DWI changes. This T1 hyperintensity is thought to be because of petechial hemorrhage in this particular region in the setting of non-ketotic hyperglycemia causing these movements. Good thing is these are self-resolving. Just treating the underlying condition, that hyperglycemia, addressing that is sufficient enough. Sometimes you might need some antidopaminergic medication, especially the atypical antipsychotic medications or dopamine depleting medications like tetrabenazine, just for less than 30 days might be necessary in about 10% of the cases. Otherwise, it's just self-limiting. That's all. Thank you so much. I'm happy to take any questions.
Thank you, Dr. Jain. That was again an elaborative display of all your case series with those wisdom added to that. So we have both our neurophysicians. I'll take their comment each on a time, then we'll go to the questions. Subbaiah sir, what is pertaining to the movement disorders in ICU? So please kindly give your review. Okay, you have been working with the Intensive Care Association for maybe a few decades, from the last few organizations to Yashoda organization now. So what is the common movement disorder which you come across, and what were the common clinical pearls you will like to actually throw to the intensive care team? Sir, unmute yourself.
Thanks, Dr. Jain, for your nice talk. So it's endless. So yeah, it's very interesting to have this critical care review with movement disorders. So ICUs, yes, we often see most of the cases. The most difficult thing which you almost, I mean, we have seen most of the cases. I can tell you, we have seen case of lamotrigine causing serotonin syndrome, linezolid causing serotonin syndrome. Linezolid is one of the important antibiotic where, I mean, prolonged course may cause definitely serotonin syndrome. And I still remember one of the cases we were showing movement disorder case, which I mean, drug-induced dystonia child. Of course, though I'm not a great fan of pediatrics, so they forced me to see the case, and it was diagnosed as seizure. The patient is on medical management for anti-epileptic with anti-epileptic drugs. So patient still having seizures. So we did a video EEG. So surprised to see that patient is on metoclopramide. So metoclopramide is one which can sometimes cause acute dystonias, which can mimic seizures. That is one interesting case what we have seen. And the most important thing, I feel, Dr. Zain, I think you should give inputs regarding this one. Most of the times we diagnose Parkinsonism, then dystonias and other movement diseases. But one important thing I think we often miss in the ICUs is malignant catatonia. Malignant catatonia. So which sometimes we feel it is neuroleptic malignant syndrome. Of course, sometimes it is very difficult to differentiate between neuroleptic malignant syndrome and malignant catatonia. So yeah, even they say that when I went back to the literature, most of the times we find it difficult. 20% of the sometimes we have difficulty in differentiating both the things. I would like your inputs regarding malignant catatonia, where sometimes in ICUs we see the patients, they were not taking the Parkinsonism medications. I mean, I think malignant catatonia is one underdiagnosed in our ICUs. That's what I feel. Commonly, of course, we see Parkinsonism, neuroleptics, then we see serotonin syndrome and all those things. But I think one case which we miss is this one. One more important question I want to ask you. How frequently, you want to answer the first question so that I can...
Better, sir.
Yeah.
Sure. So malignant catatonia, as you said, it's unfortunately underdiagnosed and sometimes missed, and which can be pretty lethal too. And usually the history and the medications can help in, especially history of schizophrenia. Somebody who's not, there were no new changes in the medication in the recent past, but they can go into this malignant catatonic phase just as a part of that schizophrenic picture. When there is no time lock between your change in medications and the clinical picture, that can make you think about malignant catatonia. But when there is time lock, for example, neuroleptic malignant syndrome, many a times, 90% of the cases happen within day 5 to 15. Parkinsonism hyperparesia syndrome, many times within 1 day of stopping the medication or something has happened. But malignant catatonia, not exactly time locked. And the second thing is, if you're just not sure, you're not getting that particular history, I think it's okay to go ahead and do empiric treatment with IV benzodiazepine, which is treatment of choice here. Giving that a trial and seeing the amount of response is one way to do. And even if you see partial response, same like, you're thinking about some seizure, status epilepticus picture, sometimes you just have to give the trial and look out for the difference. If you see even at least some response, then depending on that IV infusion of benzodiazepine would be the way to go. Now, in catatonia, you'll see more of Gegenhausen picture rather than rigidity, which you see with neuroleptic malignant syndrome or Parkinsonism. That can be quite complicated. It's not as easy as I tell even in the ICU setting. I don't have a better answer. We have had at least 2 such cases where we did not get that background history there. We did benzo trial and it helped us.
Just
we also nowadays, I think we are following that one. Sometimes because we have seen 2 cases where typically they were NMS like picture, but the CPK levels were normal. So I mean, just went back to the literature, and I think we gave that lorazepam 2 mg repeated. Then patient got totally improved. From there, that insights have developed that malignant catatonia. I think that should be a good take-home message to all the critical care consultants, where sometimes we overdiagnose other diagnoses, and malignant catatonia is one which responds well with, just a therapeutic, a trial of lorazepam. What do you say, Dr. Zain?
Yes.
And the second thing is, most of the times this NMDA receptor encephalitis, how many cases you see seropositive? Suppose you have a case of seronegative and still that EEG is not picking up. So we really land up, are we really dealing a psychiatric case, or are we really dealing our own neurology case? So do you face these problems sometimes? Because it is sometimes very difficult to, it's easy to convince the critical care consultants because of their respect towards us, but attendance, they don't have all those things. So we should be very dogmatic, and we should be very much sure what we are dealing sometimes. Can you give some inputs regarding this NMDA with seronegative?
Right. In seronegative, like again, when the serum is negative, as I mentioned, CSF is must in this case. CSF anti-NMDA has higher specificity and sensitivity compared to the serum. And this is what, not all antibodies have this kind of picture, but NMDA is something to remember. That's point number 1. Point number 2, sometimes you will, with your differential diagnosis, you'll just have to repeat the lumbar puncture. That's other way to do it. But as I said, clinical diagnosis is still more important than all these things. We have encountered, as you just said, we have actually, and I've seen a patient This was just a 15 or 16-year-old girl. And for about 2 weeks, she has this new onset psychiatric problem, and then comes with these movements, and those movements were absolutely psychogenic. They were like clear, straightforward psychogenic movements. Then I told our pediatric neurologist, hey, this looks like a psychogenic case. I don't think there's any problem that you have admitted the case. They said, no, mother is very insisting that this is what it is, and serum, the ND and MD, everything came back positive, negative, sorry. Then I said, okay, you know what, for the benefit of doubt here, let's just go ahead and do the CSF and MD, and it does come back weakly positive, weakly, not high positive, weak positive, and God gets treated with this immunosuppression and improves. So the point, this one case really taught that spectrum which I've shown, all those graphs, sometimes it can be just straightforward psychiatric picture only. Even then, you got, young person, acute onset, you got to think about those different diagnoses. Again, the emphasis which I want to lay here is you don't want to miss a treatable condition. Just you have to give more and more benefit of doubt with your clinical differential diagnosis, and just go ahead and do that empiric treatment, and then probably repeat the lumbar puncture. Even then, you will never cross the 80%. I think even with repeat lumbar puncture, it's 90%. You'll not cross that sensitivity and specificity.
Just to continue rolling the ball, so we have few questions from our audience. So we'll take those questions from our clinicians. You explained the myth related to the epilepsia partialis continua in one of the cases. So
Yes.
just a little more explanation related to that during the sleep, or how it actually.
Right. So EPC, good number of times, any seizure, good number of times can persist in sleep. But what I'm trying to say is it can also resolve in sleep. Even then it can be a seizure. That's the message I want to convey. Just a movement resolving in sleep does not rule out the concept of seizure. That's one thing I want you to remember. Point number 2, when you see a patient with epilepsia partialis continua, good number of times the EEG can be normal too, right? So that's when that particular patient whom I have shown you, actually initial EEG was negative, then led to depth electrodes. That's what has picked up the deeper temporal region, epileptiform discharge. Eventually, the scan also correlated with that and got that addressed.
Yeah.
But EPC, second take-home point is epilepsia partialis continua, and these patients can be in the ICU. They can have normal EEG too.
Dr. Sagari, ma'am, Dr. Sagari, can you hear us? Dr. Sagari, you are there?
Hello.
Yeah, Dr. Sagari, ma'am, can you switch on your camera? Yeah, ma'am, there were questions related to in ICU, how do you actually diagnose Parkinson patients with maybe new onset de novo Parkinson? What is the clues you wanted to convey to your critical care colleagues?
Right.
Dr. Sagari will take this question, then we'll come back to you. Yeah.
Okay, sure.
Clues for?
Dr. Sagari, we are trying to learn from you. We do see a elderly patient landing in ICU with different other comorbidities and all. How do you suspect a possibility of Parkinsonism in an ICU patient? What are the clues or the clinical pulse you wanted to give to the critical care colleagues?
That is a clinically we are see for the tremors, bradykinesia.
So in ICU, how frequently you get this kind of referrals where you pick up a de novo new onset Parkinson disease which has been suspected during the ICU stay?
So frequently I'll get, but that most of the times it turns out to be essential tremors than Parkinson.
Not a Parkinson. The essential tremors has been given as a referral as a Parkinson.
Yes, I've seen so many times.
Okay. Dr. Jain, what is your take on this?
Right. So, when you're looking out for Parkinsonism, something which will fall in place in a synchronous fashion is you'll have decreased eye blink frequency, the volume of speech might have been decreased, there's some spontaneous slowness of movements, there'll be rigidity on examination, there can be tremor on examination, which is present at rest. As Dr. Sagari has mentioned, tremor will be more action induced in essential tremor, but it's often something, mislabeled. Right. Now, these ICU setting patients, many a times you may not have that opportunity to make them walk, but if you happen to see that, they'll also have shuffling gait pattern and, shuffling gait or freezing. So when you see this clinical picture, you think about Parkinsonism, right? Very next step when you think about Parkinsonism is it present in the left side of the body or the right side of the body, or is it symmetrical? This is what you got to think. The reason for that is when it is symmetrical, you got to think about a different differential diagnosis. When it is asymmetrical, it's different. Is it present in the upper half of the body or the lower half of the body? Lower half of the body, usually it comes with some vascular Parkinsonism or a normal pressure hydrocephalus. Unilateral worse is more with Parkinson's disease. Bilateral is more with drug-induced Parkinsonism. Now, when you see this kind of clinical scenario, again, always take a step back, look at all the medications, see for any drug exposures. Usually drug-induced Parkinsonism starts within 1 to 3 months of exposure to these antidopaminergic medications. Do that time locking thing, see that if it syncs with that. Stopping that offending medication is sufficient enough if it is drug-induced Parkinsonism. Now, some of the other clinical scenarios where you can encounter, as I said, neurology is all about where the pathology is. Whatever is going to affect your basal ganglia can cause these movement problems, including Parkinsonism. One of the good example for this, which you might have seen in an ICU setting, is extrapontine myelinolysis or osmotic demyelination syndrome. Pons is something which you see, but when you think about away from pons, basal ganglia is the second most common affected region. And sometimes you can have combination of both. Again, that is also a treatable condition where Parkinsonism is the most common movement problem which can happen in that, right? And I've shown you some lesions which are happening in the basal ganglia. Any of these can cause Parkinsonism too.
There was one more question related to how do you differentiate a pseudo seizure with a seizure-like activity in an ICU setting?
Right. I always encourage, I tell this to our ICU physicians too, and in hospital. When patient is admitted to the hospital, you're thinking about psychogenic movement problem or psychogenic seizure. You obviously, there's some movements, you do EEG, you thought about seizure, EEG is negative, you have ruled out seizure, then instead of just jumping on to saying that this is psychogenic, think about, hey, I just heard about movement problems. Can this be some kind of movement? Can this be some kind of myoclonus? Can this be some kind of NMDA? You got to think about all these things. So when we know about those, then we'll think broadly too. And that's the whole point about the education here. I always tell our colleagues, consult neurology before jumping on to that diagnosis of psychogenic. Let us deal with it. Let us come up with that final diagnosis. Let us talk to the family. Let us do the counseling to that. If it is psychogenic, let us do that counseling, which plays the most important role in the management of psychogenic. It's not malingering. It's conversion problem where they're not doing it intentionally, which will require a lot of counseling too.
Dr. Sagari, I want just you to actually emphasize on a recent case where we actually extended our referral to you to actually give your expert opinion on our recent patient who actually had a basal ganglia involvement. So what gave you that clue? See, initially, she never had any movement issues.
Actually, she presented with sir,
Mm.
can you give a short history? Or can you give a short presentation of that case, sir?
Yeah, so this is a young girl who has been referred to us from a tertiary care center of type 2 city with the information that this patient had a seizure-like activity and then she had sensorium dipped and was transferred to here to our ICU, where initially she had thrombocytopenia, she had some leukopenia, she had high triglycerides, she had HLH-like picture, and we actually worked up for a ANA profile and all. Lupus came positive, and there was a clue that MRI also suggesting that this looks like a lupus-induced HLH causing CNS manifestations with a continuous status seizures. If you remember, we needed multiple anti-epileptics to control the seizures, and over a time she needed a tracheostomy, and she was in a locked-in state almost with the GCS of E1, VTM1 with some rigidity earlier. And over a time, after we slowly able to control her seizure with a continuous EZ, she was referred to a rehab center for further rehabilitation. And after almost a couple of months, she came back to you with a new complaints. She started opening eyes, following commands, and over to you to actually talk about this moment issues.
Actually, she came to me after a month with twisting movements, whole body, with the trunk twisting and with the foot twisting, everything. He's very clear, attender is very clear, which goes off in the sleep.
Okay.
Yeah, right.
Which goes off in the sleep. That twisting movements and all, I felt like which goes off in the sleep, and I felt it is a secondary dystonia due to involvement of thalamus and basal ganglia and all.
Right.
So, what did you do? There was some significant improvement in her condition where the family felt you did something miraculously. What
Yes,
did you
sir, I have started tetrabenazine, clonazepam, and I've tried why I don't know. Like primary choice, I've started tetrabenazine, clonazepam, and I've given even Syndopa also. I don't know, like whether it is approved or not. I don't know, sir. But tetrabenazine, clonazepam, and Syndopa I've added. She improved with this movements after adding those drugs over a month. Not completely, but most of the like 60 to 70% movements were improved, and that foot deform like that foot dystonia and all got improved.
Yeah, Dr. Jain.
Right. So, very good case. With that, I just want to mention that anytime you see a acute or a subacute onset chorea or dystonia, obviously you'll think about Sydenham's chorea. You rule out all the basic ones. The next one to jump on is always lupus. Make sure you test for lupus. Lupus can cause these movements in acute subacute fashion. When you see this, addressing that underlying lupus, which you have already done, that is one of the treatment of choice. From symptomatic treatment of choice, you can think about antidopaminergics or dopamine depleters like tetrabenazine. Probably in this patient, tetrabenazine was your answer.
Okay. That was actually that patient visited to us last week, and Dr. Sagari also wanted you to have a look at that patient. That's what I was talking about. And I have no words to the family. The father has only daughter. He's an elderly man who acts on a films. I came to lately know he has been acting for Abdul Kalam's mimic. His hairstyle, all. Sagari ma'am, do you remember his father's hairstyle?
He will be
Acting
exactly
for Abdul Kalam's role. So he sent me the picture. I was surprised, but he never lost his belief. Actually, he kept on fighting for his daughter, and he was so happy to see after so many days he started moving and walking. Subbaiah sir, this autoimmune encephalitis has become a new area to actually emphasize. If I remember a couple of decades back, when we used to get a CSF and your encephalitis panel from viral etiologies comes negative, we used to treat them with acyclovir for 10 days, and that's it. There was nothing about autoimmune. But over a time, we now realized, okay, if my proteins are high, my cell series is normal, and my MRI is normal and is a young fellow and fitting into autoimmune encephalitis, you now started taking it to a little deeper with a contrast MRI study. Now I'm seeing a PET CT being advised, and we do a CSF panel more frequently than a serology panel. So, but Dr. Jain was pointing out it is for an NMDA that CSF has more sensitivity. Is it true for all others, including the voltage gated potassium channel, or it is only for NMDA?
So NMDA, I think CSF is more sensitive, but LG1, I think serum is more sensitive. Yeah. So, but most of the times we don't get the reports positive. Let us honestly admit.
Accept the
So LG1, the clue is hyponatremia, or sometimes elderly man or woman with all those things. And for the other one is NMDA is, as he said, young women with all those things. It's a clue. I think recently we also had one case of NORS where we got autoimmune profile totally negative. We did twice, it came negative. So ultimately patient had seizures for 44 days and it was controlled with ECT. Then we discussed with the two neuroradiologists. One said it's a post-ictal changes in MRI and PET, and one person says it is an autoimmune. Still, there is no conclusion whether it is an autoimmune or non-autoimmune. So that is a problem sometimes we face. I think we have to go more of a clinical oriented picture, because sometimes labs also don't support us telling that it is an autoimmune.
Dr. Jain, what is that PET CT's pickup, and how frequently you get this seropositivity? Here, I think we see a very few. And as Dr. Chowdhary said, we had almost a half dozen of cases where we had a seronegativity. We hardly see any of them as seropositive. And all of them responded to immunotherapy, steroid pulsing, Plex, or rituximab in combination with cyclophosphamide. And all of them were seronegative. Is it something to do with the testings or sensitivity? Where are we?
So my answer is going to be a little bit different. The reason for, unfortunately, PET scans are not approved in hospital for us, 0.
Okay.
So that option is gone, and it's a pretty costly test. Then comes to the second part of your question. If I do a PET scan after the patient gets discharged from the hospital in outpatient setting, 80% of the times it gets rejected. Now question comes, why does it get rejected and how do you handle it? The answer for that is same cases. If you think back once again, if you happen to not do PET scan, I don't think your management might have changed significantly, right? You still would stick to your clinical diagnosis as a good doctor. You still have your differential diagnosis. You're still thinking about it, still would go with that empiric treatment. So my answer is, cost-effective medicine is better. I'm not a believer in that PET scan jumping on, but we recently,
what about seropositivity? What is the seropositivity and CSF positivity? We do see a very lot of seronegative here who responds with treatment therapy.
Right. So one benefit we have is sometimes we directly call the Mayo Clinic. That's where all our antibodies get tested, right? If they're negative, we ask them to run it by some antibody detection, which are not commercially available yet. For example, we diagnosed IgLON5 before it came into the commercial picture. Then we were able to diagnose anti-KLH11 before it became commercial. Then the next picture is we can also run that serum by rat cerebellum 2 to look for any pathological findings. So these advantages are there. But see, what Dr. Chowdhary has just mentioned, same thing with us too. Many times these come back negative. The answer for that is either sometimes we are not perfect with that diagnosis, or sometimes we don't have that antibody which is discovered yet. Just in the last 10 years, there were significant number of antibodies which were discovered. We just had an 18-year-old boy who was admitted to hospital. 1 year, can't talk, can't hear, can't walk, everything in 1 year. 18-year-old boy was eventually found to have anti-KLH11 and anti-ANNA2 in the setting of seminoma, which was sitting in the chest, which eventually improved with immunosuppression and removal of seminoma. So again, this probably we would not have diagnosed 10 years back when there was no such antibody available. So we don't know. It's evolving still.
So a very interesting part to just conclude this session. Yes.
Shall I add a point, Dr. Venkat, for this one, autoimmune?
Yeah.
One more point.
Yeah.
Dr. Zain, as you said, in India, yeah, most of the third parties, they agree to pay for the PET scan. And one more thing is PET scan is always, most of the times it is over-reported. Let me admit to you honestly. And before we subject the case, we always ask whether the third party is paying, whether the patient can afford or not. Suppose if it is not there, still we treat the patients even if they cannot afford or this one. I totally agree that I think EEG and clinical examination were the best things for us to come to a conclusion regarding clinical picture. Definitely helps us rather than PET scan. Sometimes PET scan keeps us more confusion also sometimes. Over investigation sometimes keep us in more dilemma also. That's
confusion.
So this just happened. I was just sitting at Yashoda Hospital just a week ago. I was seeing a patient, and then this patient eventually turned out to be was diagnosed with Parkinsonism. Turned out to be on clinical examination a psychogenic case of psychogenic neurological problem. In the meantime, patient also got PET scan with abnormal findings. And once we told them the diagnosis of psychogenic possibility, the very next question from the family was, then why is this scan abnormal, PET scan? Then we said, clinical exam is more important. So I hope they got convinced, but we'll see.
Yeah, so I think the clinical examination, which is age old, the art of clinical examination and clinical acumen still remains its own place, still keeps its own place in the field of medicine. And that's again proven one more time in this complex neurological systems when there is a lot of overlap and more complexity is involved. And with this, I think we had a wonderful session. Dr. Jain, as usual, has been very elaborative, showing a spectrum of wide interest and also the knowledge which you carried to all of us. Thank you for sharing that with all of us and making us enlightened on those parts. And thanks, Dr. Chowdhary, who actually is the key person, who's the instrumental in bringing you into the light so that we all could actually get exposed to you. And thanks, Dr. Sagari ma'am, for your cases, which actually brought us interest into the movement disorder because we got involved in many of these patients, which actually carried us to this. From a regular intensive care critical care clinician who actually more focused on a status seizures as an emergency or some acute stroke as as an emergency. Now we are also looking at all these movement disorders, which can be acute presentation, and that too, more importantly, as you said, drug induced, including, as I've pointed out, linezolid and many common drugs which we use in day in and out as a common part of it. I thank all the participants in being there and putting a few questions to all of us. I thank all of you from the Department of Critical Care Medicine and Yashoda Hospitals, and I conclude the session. Thank you all.
Thank you. Good night.
Thank you, Zain. Good night.
Bye.